Okay.
Sorry.
An otherwise 18-year-old man is brought to the emergency department because of 1 hour history of severe testicular pain. 1 hour history of severe testicular pain that began while he was walking with his dog. He says that he had similar episode 1 week ago while he was jogging, but it resolved spontaneously within 30 minutes. He takes no medications. Vital signs are within normal limit. The abdomen is soft. There is tenderness of the left testis to palpation of the abdomen. There is erythema, mild edema, and severe tenderness to palpation of the left testis. Cremasteric reflex is absent on the left. The right testis appears normal. Which of the following is the most appropriate next step in the management?
Wait. Ready?
Yes.
It's surgical consultation for orthopexy. Testicular torsion caused by rotation of testes around the spermatic cord, compression of the blood vessel supply leads to edema, ischemia, necrosis. It classically presents testicular pain, tenderness to palpation, scrotal swelling, negative chemistry reflex. Patient may also develop nausea, vomiting, lower abdominal pain prior to onset of scrotal pain. Physical exam show high-rise intestine that is oriented transversely with the surrounding erythema. Testicular torsion is typically clinical diagnosis, although ultrasound can be used for further for if diagnosis is unclear. Ultrasound will demonstrate diminished or absent blood flow to the testis. Testicular torsion is a surgical emergency, requires surgery. Evaluation when the diagnosis is suspected surgery will allow for the torsion of the testis and of your testicular fixation of those testes to prevent recurrent torsion. Next.
Okay. A 48-year-old woman comes to the emergency. A 48-year-old woman comes to the emergency department 9 hours after she was beaten on the right forearm by another woman during an altercation in bar. Medical history is unremarkable. The patient takes no medication, vital signs are within normal limit. Physical examination show once and avulsion injury to the right forearm. The remainder of the physical examination discloses no abnormal. Which of the following is the most appropriate next step? Management of this patient's wound.
Ready?
Yes.
So is irrigation and antibiotic therapy the appropriate first step in management of a human bite is irrigation and antibiotic therapy. Human bites that penetrate the skin are high risk of becoming infected with oral skin flora, including Echinella, Fusobacterium staph, strep, viral pathogens such as HIV, herpes, and also be transmitted. Superficial infection presents as cellulitis with tenderness, warm, and erythema, but deep infections can occur which may present with pain with passive movement, crepitus, and systemic illness. This patient does not yet demonstrate any signs of infection. In this case, wound management includes irrigation, control of breathing, removal of any visible debris. The wound should not be closed because this increases the risk of infection. Routine antibiotic therapy prophylaxis is given, particularly in patients with wounds on the hand, face, if the patient is immunocompromised, or if the patient has prosthetic valve, prosthetic joint, or vascular graft. The preferred empiric antibiotic is amoxicillin clavulanate, which covers both oral, and skin flora. Antibiotic therapy only is not appropriate because wound management, including mitigation, is a key step in management of bites. Next.
A previously healthy 17-year-old boy is brought to the A previously healthy 17-year-old boy is brought to the emergency department because of two-day history of generalized weakness. Because of two-day history of generalized weakness and fatigue. She reports feeling lightheaded upon standing and says almost fainted earlier today. She also reports being very thirsty recently. She takes no medication and has no known drug allergy. On arrival, he is sleepy but easily aroused. She is 170 centimeter tall, weight is 50 kg, BMI 17 kg per meter square. Her temperature is 37.3, pulse 118 per minute, respiration 28 per minute, blood pressure 102 by 54. Pulse oximeter on room air shows oxygen saturation 99%. Physical examination shows dry mucous membrane, lungs are clear to auscultation, the abdomen is soft and non-tender. The remainder of the examination shows no abnormality. Serum studies are most likely to show which of the following abnormality.
Ready?
1 second, please.
Okay.
Okay, okay,
Is decreased by carb, diabetic ketoacidosis. Okay, let's see that one. Presents with fatigue, polyuria, polydipsia, shortness of breath, tachypnea, and diffuse abdominal discomfort. Most commonly, type 1 infections with type 1. It's caused by accumulation of serum ketones such as beta hydroxybutyric acid, acetoacetic acid, and acetone in the setting of insulin deficiency. Dysregulated fatty acid degradation and ketone synthesis occurs as a result of relative state of starvation created by insulin signaling, absent insulin. Vital signs may show tachycardia, tachypnea, hypotension, caused by severe dehydration. Yeah. Lab analysis typically demonstrates increased serum glucose and ketone metabolic acidosis and higher ion gap caused by unmeasured ions. Metabolic acidosis accompanied by decreased bicarb concentration in the serum because bicarb is consumed by um, in the neutralization of increased acidic molecules, hydrogen molecules. Treatment is to replacement of insulin, volume depletion, volume repletion, correction of electrolyte abnormalities, and treatment of any precipitating factors. Next.
okay. A previously healthy 42-year-old man is brought to the emergency department 32 hours after the onset of generalized weakness, shortness of breath, severe abdominal cramp, and sweating that begins when he was gardening. Her temperature is 37.3, pulse 52 per minute, respiration 24 per minute, blood pressure 98 by 60, pulse oximetry on the room here shows an oxygen saturation 98%. Examination shows diaphoresis, excessive lacrimation, and 2 millimeter pupils. that are reactive to light, 2 millimeter pupils that are reactive to light. Diffuse wheezes are hard. Diffuse wheezes are hard on most conditions. Abdominal examination shows no tenderness. Muscles in the 4 by 5, the extremities with prominent muscle fasciculation, deep tendon reflex of 2 plus. Babinski sign is absent, sensation is intact. Sign absent, sensation intact after decontamination. Which of the following is the most appropriate treatment immediately to relieve his symptoms? Okay, next. Okay, yes.
Okay. It is atropine. Symptoms of organophosphate, I guess cholinergic poisoning are caused by increased concentration of acetylcholineuronal junction caused by irreversible inhibition of acetylcholinesterase. Um, Irreversible inhibition of organophosphate are present in pesticides and patients can be exposed to absorption, inhalation, or ingestion. Symptoms of cholinergic toxicity secondary to organophosphate will include diarrhea, vomiting, excessive urination, lethargy, altered mental status. Physical exam may demonstrate bradycardia, hypotension, meiosis, increased salivation, tearing, diaphoresis, and evidence bronchospasm. Also, weakness, paralysis may be present. In addition to cardiac arrhythmia and respiratory failure, long-term complications include neurocognitive deficit. Treatment consists of removal of the contaminated clothing, fluid resuscitation, intubation, mechanical ventilation if indicated. Administration of atropine. Atropine acts by competitively binding acetylcholine receptors which prevent cholinergic effect of acetylcholine. Pyridoxine is used in the treatment of organosulfate poisoning and exerts its effect in the neuromuscular junction, where atropine is ineffective by reactivating cholinesterase. Benzodiazepine may be administered if patients are convulsive, so I guess have seizure. Okay. Wait, let me see what we don't give. Administration of pyridoxine reactivates acetylcholinesterase and increase the amount of acetyl where okay, where atropine does not bind. However, it should not be administered without concurrent atropine because it causes in, an initial decrease in acetylcholinesterase function.
Okay, next.
Okay.
Can you tell me the diagnosis of the ECG?
Um, is this STEMI? No, everything is STEMI for
No,
me, but
it's not
is this STEMI?
STEMI.
Not.
It's
Ah,
it's a chair shaped ECG.
it's a, it's a what?
Looks like pericarditis.
Oh, okay. I
And
guess.
in the X-ray,
Maybe that's in the X-ray. Cannot see anything in the X-ray. This is a little bit. I cannot see anything really.
hilar lymph node are
And the,
the bilateral hilar. The right hilar lymph node is enlarged.
yeah, kind of
Yes.
the bilateral. Yeah, I guess bilateral. In fact, I mean, I love it. Yeah,
Okay. Let's
yeah, I guess
read.
yeah.
A 30-year-old man comes to the emergency department because of 12-hour history of sharp stabbing, retrosternal chest pain. The pain radiates to the left shoulder and is worse with inspiration and is relieved by leaning forward. Oh, he has a cold several weeks ago. He has a cold several weeks ago. Otherwise has been healthy. He doesn't smoke cigarettes. There is no history of recent trouble. Temperature is 37.4, pulse is 92 per minute, respiration 12 per minute, blood pressure 110 by 70. Lungs are clear to auscultation. A soft friction rub is heard. A soft friction rub is heard. There is no jugular venous distension on the lower extremity. A chest X-ray and ECG are shown. Which of the following is the most appropriate next step in the management?
Ready?
Yes.
I really didn't need the ECG. Okay, acute pericarditis caused by infectious inflammation, inflammatory, malignant precipitant, and presents in pleuritic chest pain that is exacerbated by laying down and alleviated by leaning forward. On exam, patients can have a friction rub on auscultation, which is better. The patient leaning forward with the diaphragm in the stethoscope, with the diaphragm of the stethoscope over the left sternum body. Chest X-ray will typically show no abnormalities. ECG findings include diffuse ST elevations and PR depressions. Echo may also show pericardial fluid collection. A moderate or large pericardial effusion can lead to complications with a cardiac tamponade, which presents with hypotension, JVD, distal heart sound, and pulsus paradoxus. Treatment of pericarditis is typically supported with colchicine and NSAIDs. Okay.
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 Next.
Next.
Yes. A 23-year-old woman comes to the emergency department because of 3-day history of nausea, decreased appetite, moderate lower abdominal cramp that do not radiate. He has vomited once today. She has no history of serious illness, takes no medication. She is sexually active with a one male partner. They use condoms inconsistently, means occur at regular interval and last for 4 days, and her last menstrual period is 2 weeks ago, was normal. BMI is 21 kg per meter square. Our temperature is 38.1 degrees Celsius, pulse 104 per minute regular, respiration 14 per minute, blood pressure 114 by 74, pulse oximeter on the room air shows oxygen saturation 98%. The abdomen is soft. There is suprapubic tenderness to palpation with no guarding. Pelvic examination shows right adnexal tenderness. The remainder of the examination shows no abnormality. Which of the following is the most appropriate next step in diagnosis?
Ready?
1 second, please.
Okay.
Okay, let's see.
Okay. So it is measurement of beta ECG concentration. Women at reproductive age and uh, presenting for care because of pelvic pain, abdominal cramping, should be evaluated for pregnancy with measurement of beta HCG. Pregnancy is suspected when there is a missed or delayed menstrual period. Ectopic pregnancy is an abnormal pregnancy in which the fertilized ovum implants in the fallopian tube, ovary within the peritoneal and non-endometrial location. It often causes symptoms early in pregnancy because of restricted area for fetal development and commonly presents with lower abdominal or pelvic pain, vaginal bleeding. Physical exam may disclose a nasal tenderness on the side of implantation. Beta HCG is produced by placenta. It's undetectable in the serum of non-pregnant patients and double approximately every 2 days during early form of pregnancy. The HCG concentrations do not increase as expected in ectopic pregnancy, often lagging the normal expected doubling. And ectopic pregnancy is not viable. Treatment in ectopic pregnancy can be medical using methotrexate for small early pregnancies, but may require salpingectomy or evacuation with laparoscopy for larger pregnancies or in cases of medical treatment failure. Complication of ectopic pregnancy core rupture, bleeding, and hemoperitoneum. Okay. Next.
Yes. A 77-year-old woman is brought to the emergency department because of a 4-hour history of pain in her left leg after she fell at home. She is unable to bear weight on her leg. She has no history of serious illness, takes no medication, vital signs are within normal limit on examination. The left lower extremity is held on the left lower extremity is held in external rotation. The left lower extremity is held on external rotation and is 1 inch shorter than the right lower extremity. The remainder of the examination shows normal features of the following with the most likely diagnosis.
Ready?
Yes,
So it's fracture of femoral neck. Osteoporosis is a condition characterized by progressive loss of bone mineral density leading to decreased bone strength. This decreased bone mineral density often leads to fragility fractures, which can greatly decrease mobility and even lead to death in elderly. It's usually asymptomatic but can result in functional debilitating fractures with low velocity injuries such as um, ground level falls. This patient presents with inability to bear weight and left lower extremity held in external rotation. Raising suspicion for a fracture at the hip joint. Femoral neck fractures commonly present with a short and externally rotated lower extremity. Fracture of the acetabulum or fracture of the pelvis can occur with blunt injury to the pelvis and may result in inability to bear weight, but they will not typically present with extremity shortening or external rotation. Okay. Next.
yes. A 29-year-old woman is brought to the emergency department by her husband because of the history of suicidal thoughts. She has 4-year history of MDD treated with fluoxetine. During the during the interview, she said that she has been having occasional thoughts of harming herself, but she does not have a plan. She says that there are no problems in her marriage and that her husband strongly supports her. She is employed as an insurance agent. She has smoked 1 pack of cigarettes for 5 years, drinks alcoholic beverage, temperatures, heart disease, and pulse. Mental status examination shows an organized thought process. However, the patient looks away when answering the questions. If the patient is dissure, which of the following historical factors increase the risk of attempting suicide?
Ready?
Mm, okay.
Yeah?
Yes.
Okay. Alcohol use. Suicide is the most serious and acute risk for patients with depression. So physicians will ask detailed questions about the patient's suicidal ideation and recent or remote suicide attempt when there is any suggestion of suicidality. Whatever. Suicidality differs by gender. Women are more likely to attempt suicide, while men are less likely. But more likely, are less likely to attempt suicide, but more likely to be successful when they do so. The risk factor for suicide is age over 45, previous attempts, alcohol or substance abuse, chronic illness, organized plan or access to weaponry. being a mere lack of social support. In this case, the patient excessive alcohol use is the factor that most increase the risk for attempting suicide, which is a modified risk factor. When evaluating a patient with suicidal ideation, um, the physician should conduct a full psychic assessment and ask the patient directly about their intent and plan to commit suicide, while also assessing overall the risk using a validated suicide risk assessment scale. Any patient at moderate to high risk warrants further assessment by training psychologists or mental health worker in consideration for admission. The patient in such a case is discharged, a contract for safety and safe discharge plan should be established with the patient. So it's not the gender. Let me see. This patient female gender is slightly associated with an increased risk for attempted suicide, but alcohol use is a stronger risk factor. Next.
Yeah. A previously healthy 4 months old girl is brought to the emergency department because of 2 day history of fever, vomiting, loose stool, fever, vomiting, loose stool. Her parents have been giving her water to keep her dehydrated. She appears lethargic. She Her temperature is 38.2, pulse is 188 per minute, respiration is 28 per minute, and blood pressure is 60 by 30 per millimeter of mercury. Examination shows sharply spontaneous dry mucus and spontaneous breathing, dry mucous membrane. The lungs are clear to auscultation, no murmurs are heard. Abdominal examination shows of distension and tenderness. Bowel sounds are hyperactive. Sodium low 122, potassium mm, normal, chloride 100. Bicarbonate bicarbonate is low, isn't it? Or is it normal?
Yeah, it's low.
Yes,
It's
okay.
low.
Blood urea nitrogen is 26 high, and uh, glucose bit low, and creatinine zero point 0.5. Which of the following is the most likely explanation for patient's hypertension?
Ready?
Yes.
There is decreased cardiac preload. This patient presents with signs and symptoms of hypovolemic shock, most likely secondary to GI fluid loss. Acute diarrhea illness are common in pediatric patients, and they are susceptible to developing clinical significant volume depletion. Loss of intravascular fluid results in decreased cardiac preload with a consequent decrease in cardiac output, leading to a state of hypoperfusion. Pediatric patients typically present with lethargy, signs of volume depletion include tachycardia, hypotension, um, sunken anterior fontanelle drive mucous membrane. Despite the patient's parents attempt to maintain hydration after administration of water alone is less effective than co-administration with a solute mixture, and losses from GI tract can quickly exceed the ability to replace them entirely. The patient requires emergency volume resuscitation and inpatient management. It's not DNE, it's DNE. Increased stroke volume does not occur in hypovolemic. In fact, the decreased cardiac preload results in a decreased stroke volume. Tachycardia and increase in sympathetic don't occur as a compensatory mechanism for the decrease in cardiac output in attempt to maintain perfusion to vital organs. They do not explain the patient hypertension. Next.
Yes. 58-year-old woman, a 58-year-old woman comes to the emergency department 3 hours after an onset of heart palpitation. She has had 6.8 kg weight loss during the past 3 months. She reports, oh, she always feels warm. During this time, she has no other symptoms. She has no history of serious illness, takes no medication, no history of serious illness, takes no medication. She is 5 feet 6 inch tall, weight is 48 kg, BMI 17 on arrival. She is diaphoretic, her temperature is 100.5, 100.13 Fahrenheit, pulse is 130 per minute, respiration 24 per minute, blood pressure 138 by 79. A photograph of the neck is shown. Which of the auscultation of which of the following is the most appropriate next step in the management?
Ready?
Yes,
So it's propranolol, large multilobular subcutaneous mass at midline in the neck of this middle-aged woman. The symptoms hyperthyroidism is consistent with toxic multinodular goiter. In this condition, thyroid follicles become hyperactive either autonomously or secondary to antibody activation and begin producing excess T4. This patient is acutely symptomatic from increased T4 with fever, diaphoresis, tachycardia, palpitation, hypertension. T4 causes this effect by stimulating B1 receptors in the heart and increasing adrenergic tone along with basal metabolic rate. She also demonstrates signs and of chronic increased T4 such as weight loss. Other symptoms, though not present in this case, can include muscle weakness, diarrhea, menstrual abnormality, insomnia. Treatment of symptomatic hyperthyroidism begins with oral propranolol, which inhibits beta receptors and decreases the adrenergic symptoms of hyperthyroidism. Treatment also includes antithyroid medications such as PTU, iodine, steroids, along with ablation or surgical intervention. Next.
yes. A 54, sorry, a 34-year-old woman, gravida 1 para 1, a 34-year-old woman, gravida 1 para 1, comes to the emergency department because of 7-hour history of moderate diffuse lower abdominal pain, vaginal bleeding, temperature is 100.1 degree Fahrenheit. She says she felt well until this morning. 1 week ago, had 1 week ago she had an uncomplicated spontaneous vaginal delivery of a female newborn at term. Her postpartum vaginal bleeding had been decreasing daily until today, when she began passing some blood clots and soaking through a sanitary pad every 2 hours. Her current temperature is 37.9 degrees Celsius, pulse 110 per minute, respiration 20 per minute, blood pressure 102 by 66, pulse oximetry on room air shows oxygen saturation 99%. On examination, the abdomen is soft, diffusely tender to palpation of the lower quadrant. There is no rebound tenderness or guarding. The uterine fundus is firm, tender, palpable, inferior. The uterine fundus is firm, tender, palpable, inferior to the umbilicus. Her hematocrit is 29%, leukocyte count is 15,200. Pelvic ultrasound show echogenic material in the uterine cavity. Which of the following is the most appropriate next step in the management?
Ready?
1 second. Okay, ready. Ready?
Yes. So it is. Where did I go? Dilation and curettage. Postpartum hemorrhage is a relatively common complication of childbirth, whilst some postpartum vaginal bleeding can persist for up to like 8 weeks following delivery. Late or secondary postpartum hemorrhage occurs more than 24 hours after delivery and is characterized by significant uterine bleeding, such as passage of clot of bleeding that soaks menstrual pad in less than an hour. A common cause of secondary postpartum hemorrhage is retained products of conception, which can become infected and cause postpartum endometritis. Endometritis presents with fever, tachycardia, abdominal pain, uterine tenderness, leukocytosis, and indisposition. Ultrasound can identify the retained products of conception by disclosing echogenic material in the uterine cavity treatment. For retained products of conception include cervical dilation and curettage to remove the product. This patient will also need antibiotics to treat associated infection. Next, we take a quick break.
Okay. A 36-year-old man with HIV infection comes to the emergency department because of 1 hour history of nausea and sharp intermittent pain in his right mid-back that radiates to the right flank. He has had 2 episodes of vomiting during this time. His only medication is atazanavir. His temperature is 37 degrees Celsius. Pulse 110 per minute. Respiration 20 per minute. Blood pressure 140 by 60 millimeter of mercury. Pulse oximetry on room air shows an oxygen saturation of 100%. There is tenderness to percussion of the right costovertebral angle. No abdominal tenderness noted. Lab studies shows hemoglobin 14, leukocyte count 17,000, platelet count 250,000, sodium 140, potassium 4.5, chloride 100, bicarbonate 25, glucose 100, creatinine point, glucose 100, creatinine point 9, urine RBC 10 to 20, high powerful WBC 1 to 2, nitrate negative, leukocytosis negative. Which of the following is the most likely to confirm the diagnosis?
Is it
Ready?
CT scan or is it uric acid? Let's see, let's see, let's see. I don't know. Something BND, BND. Azatanivir. Does it called kidney stone? Navir, Navir, Navir. Yeah, I think it causes kidney stone. Okay. So it's a CT scan. CT scan of the abdomen is most likely to confirm the ureterolithiasis in this patient with right flank pain and hematuria. Risk factors for development of nephrolithiasis include diabetes, metabolic syndrome, male sex, prior GI bypass, calcium-containing stones, including calcium oxalate and calcium phosphate are most common varieties, although kidney stones may also be composed of cysteine, struvite, and uric acid. The typical presentation of kidney stones that have become lodged in the ureter includes severe intermittent sharp flank pain, severe intermittent sharp flank pain with either gross or microscopic hematuria, leukocytosis, occasionally evidence of a concomitant urinary tract infection, mild abdominal. Plain X-rays were traditionally used for diagnosis. Urate stones are radiolucent, and given the availability and sensitivity of advanced Imaging non-contrast CT scan of the abdomen is now the preferred imaging modality for definitive diagnosis. Acute management depends on the size and location of the stone. Um, in addition to complicating factors such as abnormal anatomy or the concurrent presence of UTIs, Stargardt calculi, which occur commonly in the setting of infections with urease producing bacteria, often must be surgically removed. Additionally, stones larger than 6 millimeters often require intervention because they are unlikely to pass on their own. For smaller stones in clinically stable patients, treatment with hydration and pain control. Medications such as tamsulosin may be used to augment stone passage. At times, urine should be strained to assess the passage of stone, though data and practice patterns on this are mixed. It is not measurement of serum uric acid concentration is not necessary in this patient because it does not have evidence of a gout flare. While some kidney stones are composed of uric acid, serum uric acid measurement serum uric acid measurement does not reliably predict the composition of any kidney stones. Okay. Next.
Next, a 25-year-old man is brought to the emergency department 30 minutes after collapsing near the completion of 26-mile run in the warm, humid weather. On arrival, he is upturned and warm. Temperature is 40 Temperature is 40, 104 pulse, 120 per minute, regular respiration at 40 per minute, blood pressure 85 by 50 millimeter of mercury, blood pressure 85 by 50 millimeter. Examination shows moist, gummy skin, hematocrit 55, leukocyte count 15,000. Shift to the left, platelet count is 55,000, platelet count is 55,000. Blood urination 50, creatinine 2.5, ALP 100, AST 500, ALT 500, CK 1000. Which of the following is the most likely diagnosis?
Hmm.
Ready?
One moment. Heat stroke, heat exhaustion, heat stroke, heart. Mm. Okay, ready. So it's heat stroke. Oh my goodness. Heat stroke is characterized by an increased body temperature that occurs when the body is exposed to high temperatures and high humidity, and it commonly occurs in young athletes, in elderly patients with impaired thermoregulation capacity. Excessive heat exposure and increased core body temperature leads to cardiovascular and neurologic dysfunction with secondary tachycardia, tachypnea, hypotension. Vasodilation or superficial blood vessels may lead to multi-organ system failure, including hepatic and renal ischemia, rhabdomyolysis, and DIC. Treatment includes cooling of the patient with fines of ice or ice water, continuous core temperature monitoring, mm, and support of airway breathing and circulation. History of generally requires neurologic symptoms to be diagnosed, like collapse in this patient. Paralysis exhaustion presents similar but an intact neurologic examination. It's not D. Rhabdomyolysis refers to the abnormal breakdown of skeletal muscles and may occur secondary to crush or compression injuries, excessive exertion, alcohol abuse, medications, toxic substance. Lab findings include increased serum concentrations. Lab finding could increase serum concentration of myoglobin and CK. While rhabdomyolysis may lead to myoglobinuria renal failure, it does not typically cause hyperthermia and shock.
Next.
Hyperthermia and okay.
Next.
Yeah, sorry.
Okay. A 60-year-old woman is brought to the emergency department. 60-year-old woman is brought to the emergency department a 12 year because of 12-hour history of moderate diffuse abdominal pain and vomiting 2 weeks ago. She underwent sigmoidectomy for perforated diverticulitis. Her postoperative course has been otherwise uncomplicated. She has not had fever, diarrhea, pain with urination. Her last bowel movement yesterday was normal. She has not passed any flutters. Her medication are ciprofloxacin, metronidazole, oxycodone, acetaminophen. On arrival, the patient is in moderate distress. She is awake and alert. Her temperature is 37.9 degrees Celsius. Pulse 100 per minute, respiration 20 per minute, blood pressure 140 by 65 millimeters of mercury. Pulse oximetry on true mirror and oxygen saturation is 98%. Cardiopulmonary examination showed no abnormality. The abdomen is moderately distended and diffusely tender to palpation in all four quadrants. The surgical incision is clean, dry, intact. Bowel sounds are decreased. Chest and extra of the abdomen shows multiple loops of distended small bowel, multiple loops of small distended small bowel with air fluid levels throughout. No air is noted in the rectum, during the most appropriate next of the mandible. Ready?
No moment. No disimpaction or exploratory laparotomy. Every levels. No air in the rectum. Okay. Now we got it wrong again. Okay, ready. Is insertion of nasogastric tube. Jesus. Bowel obstruction is the most likely diagnosis in a patient with previous abdominal surgery presenting with abdominal pain and obstipation. Obstruction of the bowel occurs from a partial or complete blockage of the bowel lumen and typically presents with nausea, vomiting, abdominal pain. Partial obstruction allows a degree of continued flatus with diminished stooling, and complete obstruction, no flatus and no stool. Obstruction has many potential causes, although the most common are post-surgical peritoneal adhesions and hernias. On physical exam, patients typically present with abdominal pain, distension, tympanic percussion, and high-pitched hyperactive bowel sounds. Potential complications include bowel rupture and necrosis, which can result in sudden onset peritoneal signs such as rebound, tenderness, guarding. X-ray of the abdomen typically discloses multiple F3 levels in the setting of the dilated bowel loops. Management requires bowel rest, insertion of an nasogastric tube for decompression, and increase in an IV hydration followed by surgical intervention if the obstruction does not auto-reduce. Partial obstruction may resolve with monitoring, supportive care, and bowel rest, whereas complete obstruction may or any uncomplicated wait, whereas complete obstruction or any complicated partial obstruction generally requires exploratory laparotomy. Okay, it's not B. Exploratory laparotomy can be done for obstruction that does not auto-reduce with bowel rest and decompression, but will not be appropriate prior to insertion of nasogastric tube for management. Surgery is also indicated in case of perforation or necrosis. but this patient does not show any signs of yeah, peritonitis. Manual disinfection can be helpful in cases of constipation and obstruction rectal stool. In cases of constipation and obstructing rectal stool burning. However, this patient obstipation is caused by interperitoneal process, not constipation. Okay, next.
Yes. A 68-year-old man comes to the emergency department because of 2 week history of abdominal cramp. 2 week history of abdominal cramp after eating. He has also noticed 2.3 kg. He has also noticed 2.3 kg weight loss during this time. He has had occasional he has had occasional loose stool, but does not report any blood. He has hypertension, congestive heart failure medications, decoxynamlodipine. His medical records are 6 minutes. His medical records from 6 months ago shows a left ventricular ejection fraction 20%. He has no he 20%. He has no known drug allergy. On arrival, he appears thin, uncomfortable. His temperature 37, pulse 67, respiration 18. Pulse oximeter on the room air show oxygen saturation 97%. Cardiopulmonary examination discloses S3 and bilateral or basilar crackle. The abdomen is soft. The remainder of them, which of the following is the most applicable?
Ready?
What is your diagnosis?
Between mesenteric ischemia or the colitis,
Okay,
the ischemic colitis. But I think it's mesenteric, chronic mesenteric though.
because the risk factor related to cardiovascular like hypertension, heart failure.
Mm, no, I think because of the history of when he eats, he has abdominal pain when he eats. But
Okay,
maybe, yeah, maybe the hypertension is a risk, but I don't know. Maybe that friend, yeah. CT angiography is the most appropriate next step in diagnosis. This patient with heart failure with reduced ejection fraction, recent weight loss, and postprandial abdominal pain most likely has non-occlusive mesenteric ischemia. Mesenteric ischemia can occur secondary to thrombosis of the mesenteric artery or can result from low flow cardiac states leading to intestinal hypoperfusion. The blood supply to the intestines is primarily derived from the superior mesenteric artery and inferior mesenteric artery. Following a meal, the blood flow to the intestine increases to aid in the digestive process. In non-occlusive mesenteric ischemia, constriction of the mesenteric artery in combination with the decreased cardiac output leads to supply-demand mismatch and subsequent intestinal ischemia. This is often experienced as postprandial pain, which may make some patients avoid eating altogether, thereby losing weight. The diagnosis is made by CT angiography, which shows narrowing of the mesenteric vessels and the branches when the condition is secondary to um, heart failure. We reduce ejection factor therapy is aimed to improve the cardiac function. Okay, next.
okay. A previously healthy 32-year-old woman is brought to the emergency department 30 minutes after sudden onset of dizziness, numbness, and neck pain. She was participating in a vigorous aerobic class when she began to have sharp pain on the right side of the neck that spread to the back of her head, followed by a sensation of spinning and left-sided numbness. She is alert and oriented to person, place, and time. Her temperature is 37.6 degrees Celsius. Pulse is 90 per minute regular. Blood pressure is 130 by 80. Examination shows mild narrowing of the right palpebral fissure. The right lower extremity is the right pupil is 2 centimeter and the left is 4. The right pupil is 2 and left is 4, both reactive to light. Fundoscopy examination show no abnormalities. The palate does not elevate on the right. The tongues protrude to the midline. Muscle strength. Deep tendon 2 plus Babinski sign is absent. Sensation to the pinprick is decreased over the entire left leg and the right side of the face. The gait is ataxic, the speech is slurred. There is intention tremor of the right lower extremity, which of the following is the most likely diagnosis.
Jesus. Ready?
One moment, please.
Mhm.
Okay.
So it is vertebral artery dissection. Oh my God, I suck at emergency med. I swear. Vertebral artery dissection is the most common cause of stroke in a young, healthy patient and can be caused by spontaneous dissection or can be secondary to trauma. Okay. Even mild trauma such as quickly turning the neck, exercise, or chiropractic activity may be associated with vertebral artery dissection. Patients can present with symptoms such as neck pain, Horner syndrome, cranial neuropathies, dysarthria ataxia. Horner syndrome is characterized by the triad of ipsilateral meiosis, ptosis, narrow palpebral fissure, and hydrosis. Horner syndrome characterized from lesions along the sympathetic pathway. Vertebral artery dissection is associated with lateral medullary infarction of Wallenberg syndrome, characterized by ipsilateral ataxia or extremities engaged ataxia, and can be associated with nystagmus and dysarthria. Carotid artery occlusion can cause decreased flow to the brain or embolic events resulting in cerebrovascular ischemia. Patients can have a carotid bruit on exam. Carotid plaques can embolize. They can cause ocular ischemia, contralateral hemiparesis, midsensory loss, homonymous semianopia. Hmm, okay.
Okay.
Mhm.
Can you give me 5 minute break? I'm coming with a coffee. Feeling very
Ready?
okay. A 15-year-old girl is brought to the emergency department by paramedics after a prolonged extrication from a car that was involved in a rollover motor vehicle collision. At the scene, her pulse is 130 per minute, systolic blood pressure is 70 millimeter of mercury. He was intubated by paramedics and received he was intubated by paramedics and received 2 liters of crystalloid fluid during transit. On arrival, in the emergency department, she is on arrival in the emergency department. She is unresponsive, voice to stimulation, and has an obvious left femur fracture and winches to abdominal palpation. An additional 2 liters of crystalloid fluid are administered. Her temperature now is 37 degrees Celsius, pulse is 130 per minute, respirations are 25 per minute, blood pressure 75 by 50 hematocrit is 15%. In addition to continue the crystalloid resuscitation, which of the following is the most appropriate next step in the management?
Ready?
1 minute, please. Yes, ready.
Is administration of good. Wait. Oh, I was like, this don't make sense. Wait. The question is missing here. Let me put it on. This does not make sense. On the copy in Gemini paste. Mm, 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 mm. Why is it taking so long? Okay. Based on the patient presentation, she is profound hemorrhagic shock and unresponsive to crystalloid for resuscitation. High energy trauma. She had an accident, persistent shock. The pulse was 130, blood pressure 75 over 50, which has not improved despite giving them like 4 liters of fluid. This indicates that the body compensatory mechanism are failing and the fluid is not addressing the underlying problem. Massive hemorrhage,
So, what is the
left
answer?
massive transfusion protocol.
The answer is
Um,
the option E. Transfu
option what?
Option E. Transfuse type O RH negative
No, they
pancreatic.
didn't specify. They
Sorry,
didn't specify. They didn't specify.
I have
Uh,
found the. I have found from
oh, you
another.
found it? Oh, you found it. Okay, okay, okay.
I'm
Let's just
sending
go back
you here. Okay, okay. You can see from the chat.
from the chat. Okay, E.
Okay,
And then why is it not the whatever the cross match on the? Okay, it doesn't say. Oh, it says since is unstable, there is no time for type and cross match. So you do type 0 and okay, and RH negative. Okay,
okay.
next.
A 54-year-old man with a 54-year-old man with type 2 diabetes mellitus. A 54-year-old man with type 2 diabetes mellitus is brought to the emergency department by paramedics 30 minutes after his wife 30 minutes after his wife found him lying unresponsive on the bed. His finger stick blood glucose concentration is 20, so she called 911. His medication are glimepiride and metformin. She has no known drug allergy. At the scene, paramedics could not obtain IV access and transported him to the hospital. On arrival, the patient is diaphoretic and moaning softly. He does not cooperate with the examination. Temperature is 94, pulse 90, or respiration are 8, blood pressure 134 by 86, pulse oximeter in room air is 96%, cardiopulmonary examination shows no abdominal, no rashes, no finger stick, blood glucose is team, the nurse continued to have difficulty obtaining IV access. Which of the following is the most appropriate management while awaiting IV management? Okay,
Okay, so
ready.
the answer is the intramuscular administration of glucagon. Intramus is the most appropriate next step of this diabetic patient with severe hypoglycemia and no IV access. The treatment of severe hypoglycemia in diabetic patient requires administration of either carbs or glucagon. If IV access is available, carbs can easily be given like 50% dextrose. However, in this case, IM glucagon is a fast and safe way to reserve the hypoglycemia in a patient impaired consciousness and no IV access. After administration of glucagon, the patient must be closely monitored. IV access obtained because the effect of glucagon is transient. After IV access is available, a continuous infusion of glucose will likely be necessary. Any patient with hypoglycemia taking long-acting oral hypoglycemia sulfonylureas requires prolonged monitoring or admission because rebound hypoglycemia is happening, can happen. And application of, no, that's not the one I was looking for. Where is it? E. Rectal administration of dextrose is a less timely and reliable um, method of increasing blood sugar. This patient is experiencing severe neurologic manifestation of hyperglycemia. The quickest method of increasing his blood sugar is necessary. Okay, next.
A 47-year-old a 47-year-old man is brought to the emergency department by paramedics. A 15 minutes after he was involved in a motor vehicle collision in which he was the restrained driver. The patient was traveling at about 5 miles per hour, 8 kilometers per hour in a parking lot when his car stuck at a parked vehicle. Paramedics says that the damage to both vehicles was minimal. The patient says he consumed two beers earlier in the morning. On arrival, he is awake, alert, and fully oriented. His temperature is 37 degrees Celsius, pulse is 88 per minute, respiration 14 per minute, blood pressure 128 by 78 millimeter mercury. Examination shows tenderness and swelling of the right elbow, but no other abnormality. The physician recommends that an X-ray of the elbow was performed. The patient says that he would prefer to leave. He is able to verbalize the risk of leaving using his own hands. Which of the following is the most appropriate next step? Mm, okay.
Ready?
Yes.
Okay, so is allow the patient to live against medical advice. Um, Patient autonomy is one of four common medical ethical principles: beneficence, no maleficence, and justice. Other autonomy positions that patients have the right to make the decision provided that they have the capacity to do so and they have been provided with appropriate information for use in making such a decision. Consenting adult with decision making capacity has the right to refuse some or all aspects of medical care, even if such a decision may result in short or long term morbidity and mortality. Um, in this case, the patient is declining further workup and treatment of MSK injury by the accident. Provided that this patient has capacity and the caring physician has explained the benefit, risk, and alternative for not performing the X-ray of the elbow, the patient may elect to refuse and then be allowed to live against medical advice. It's not C, detain the patient until blood alcohol levels are measured. Um, Violates the principle of ethical principle or autonomy. because this patient demonstrated decision-making capacity by being able to verbalize the risk of even in his own words, and is not suspected to be impaired. There is just justification to detain the patient and perform test again. It's his will. Okay.
Next, the 72-year-old man a 72-year-old man is brought to the emergency department a 1 hour after losing consciousness while eating at home. 1 hour after losing consciousness while eating at home during the past month. She has had intermittent one episode of vertigo, nausea, double vision, and numbness of the left side of the face. Numbness of the left side of the face. She has 20-year history of hypertension treated with enalapril. On arrival, she is intubated and mechanically ventilated because of poor respiratory effort. She is unresponsive to commands. Her temperature is 37.1 degrees Celsius, pulse 72 per minute, blood pressure 160. I anti her. She is overriding the ventilator with respiration 14 per minute. The pupils are pinpoint. There are no horizontal eye movements spontaneously or on doll's eye oculocephalic maneuver. There are no spontaneous movement of the extremities except for an occasional extensor posturing. Deep tendon reflex at 2 plus throughout. Babinski sign is present bilaterally. A complete blood count and serum electrolyte glucose concentration is within the reference range. A CT scan of the head shows CT scan of the head within 2 hours of the arrival shows viability. Which of the following is the most likely mechanism of this patient? What is its
Okay.
diagnosis? There is extensor posturing. There is horizon. Uh,
Ready?
yes.
Is brainstem ischemia. Okay. This patient is showing signs of brainstem dysfunction, including altered level of consciousness, poor respiratory effort, posturing, and negative oculocephalic maneuver on exam. Dysfunction of the brainstem can also present with cranial nerve dysfunction, dizziness, vertigo, gait instability, symptoms that the patient had been experiencing prior to these acute episodes. To this acute episode, Babinski sign or extension plantar response is an open motor neuron side indicates damage to the corticospinal tract, a descending motor tract located in the CNS. The Babinski sign is present when lateral part of the plantar surface of the foot is firmly struck and the hallux window. The doll's eye oculocephalic maneuver refers to brainstem reflex that occurs in normal adults in which the examiner moves the patient's head and the eyes move in the opposite direction to hold the patient's gaze on an object. In a negative oculocephalic reflex, the patient eye remains midline, which indicates severe brainstem dysfunction. The cause of brainstem dysfunction in this patient is likely brainstem ischemia, which is often not disclosed on CT scan when acute. MRI is more sensitive for diagnosis. Patients with brainstem ischemia can have stuttering course, which this patient experience with mild intermittent symptoms. prior to the presentation. And it's not cerebral hemispheric. Where is it? Cerebral hemispheric ischemia may not be disclosed on CT scan, but CT scan may show delayed signs of infarction. Large vaso-occlusive infarction with cerebral edema may be visible, especially on CT angiography. Cerebral neurologic deficit will include focal hemibody paresis, neglect, aphasia, dysarthria, visual field deficits. In contrast, patients with processes involving the brainstem typically present with global symptoms such as obtundation, respiratory depression, posturing, such as in this patient. Hmm, interesting. Okay, next.
Yes. A 37-year-old man is brought to the emergency department. A 37-year-old man is brought to the emergency department by paramedics 40 minutes after he sustained a stab wound to the chest during altercation. He has no history of serious illness, takes no medication. His last meal was 12 hours ago. On arrival, he is awake, alert, and speaks in clear voice. He appears anxious and is in respiratory distress. His pulse is 130 per minute, respiration 28 per minute, blood pressure 80 by 58. Pulse oximeter on room air shows oxygen saturation 84%. He receives 100% oxygen by NRV mask. Examination shows jugular venous distension. There is 2 centimeter wound over the left anterior chest wall, but no active bleeding. Decreased breath sounds are heard over the left hemithorax. Which of the following is the most appropriate next step in the management?
Ready?
1 second, please. Okay, ready?
Yeah. So it is needle thoracostomy. Tension pneumothorax can be a complication of penetrating thoracic trauma and occurs when air is able to enter the pleural but is prevented from exiting. An increasing amount of trapped air in the pleural compresses the lung parenchyma, creating an inability of the lung to expand, causing it to collapse. As the pneumothorax progresses and continues to increase in size, it can result in an tracheal and mediastinal deviation away from the affected pneumothorax. It can result in decreased venous return to the heart, which manifests with hypotension and obstructive shock. Tension pneumothorax is characterized by absent breath sounds and hyperresonance to percussion. In cases of acute tension pneumothorax, evacuating the acute air via needle decompression and aspiration permits expansion of the lung and eliminates tension in the mediastinal structure, resolving the shock. Immediate needle decompression is followed by tube thoracostomy, which promotes expansion of the lung, prevents accumulation, and promotes healing of the pleural defect. IV administration of saline can be helpful for patients with hypertension secondary to distributive shock, such as anaphylaxis of sepsis. This patient tension pneumothorax is causing an obstruction shock, and fluid administration will not resolve the problem. It's not F. Tube thoracostomy typically follows needle decompression, which is an emergent and rapid maneuver that can help temporize the patient in preparation for tube thoracostomy. Tube thoracostomy should be done under sterile conditions and requires several minutes. Next.
An otherwise healthy 37-year-old man is brought to the emergency department because of low back pain that began after he moved heavy box of books and furniture one day ago. He has been taking acetaminophen with no relief. Physical examination shows tenderness over the lumbar spinal. Uh, on palpation, perineal sensation is intact and rectal tone is normal. Muscle strength is full. Sensation is intact in the lower extremity. Which of the following is most appropriate? Next step.
Ready?
Yes.
There's no further diagnostics. The lumbosacral strain commonly occurs following strenuous exertion and is characterized by dull, aching lower back pain that does not radiate to the lower extremities and which is not accompanied by neurologic deficit. Most adults with acute lower back pain less than a month duration do not require imaging, which is of limited diagnostic value and leads to unnecessary testing. Medical expenses and yeah. Imaging may be useful for diagnosis of persistent back pain that is accompanied by severe and progressive neurologic deficit, or pain that is suspected to be secondary to certain disease entities such as vertebral metastasis, spinal stenosis, osteomyelitis, spinal epidural abscess, hepatoma, vertebral fracture. Any patient with red flags of back pain such as neurologic symptoms such as scalp, equina, conus medullary, history of trauma, malignancy, midline tenderness accompanied by fever, infectious symptoms, or history of immunocompromised may benefit from acute imaging. However, most patients with acute lumbosacral strain can be managed conservatively with ice or heat massage and light exercise provided by history and examination are reassuring and lacking red flags. Okay, next.
Yes. A previously healthy 20-year-old man comes to the emergency department 1 hour after sudden onset chest pain. 1 hour after sudden onset chest pain, shortness of breath. She says that the chest pain is worse when she takes a deep breath. During the past week, she had a pain and swelling in the left leg. She does not use oral contraceptives. She had smoked one pack of cigarettes daily for 3 years. Her temperature is 37.2, pulse 130 per minute, respiration 26 per minute, blood pressure 140 by 85 millimeter of mercury, pulse oximetry on room air shows an oxygen saturation 94%, and the lungs are clear to oscillation, and the urine pregnancy test is negative, and ECG is shown. Which of the following is the most appropriate next step in the management?
Ready?
1 second. Yes, ready.
So it is CT angiograph of the chest. CT angiograph of the chest most appropriate step in diagnosis. This young patient with new onset exertion of dyspnea, periodic chest pain, recent lower extremity swelling suggesting DVT, tachycardia, most areas PE. Well score for permanent PE can be helpful tool in determining the likelihood of DVT or PE, and the rest the most appropriate step, which can include the dimer or image based tests such as CT angiography in patients with low pretest probability and negative D-dimer effective rule of PE. Those with higher score, the most appropriate diagnostic test is CT angiography, which is a CT scan with iodinated contrast time to evaluate for pulmonary arteries. Pregnant patients or those with contraindication to CT scan or contrast can undergo VQ scans, although this imaging modality is not available everywhere. PE can be found in the main pulmonary segmental or supplemental arteries and appear as filling defects on imaging. For patients without evidence of cardiogenic shock, treatment is systemic anticoagulation, which can be accomplished with warfarin, low molecular weight heparin, and with direct oral anticoagulant. ECG findings. in PE include sinus tachycardia, right axis deviation, right bounded by S wave, blah, 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 inverted S wave in lead 1, Q wave in lead 3, and inverted T wave in lead 3. So S1, Q,
S1 Q3 T3.
okay. Next,
Okay, item 2.
item 2, yeah.
CD angiography of the chest show bilateral pulmonary emboli during transport back to the emergency department. The patient has increased respiratory distress now. Her pulse is 145 per minute, respiration 30 per minute, and blood pressure 80 by 50. Pulse oximeter here show oxygen saturation 86%, which of the following is the most appropriate next step in the management.
Mm.
We'll give low molecular weight heparin, isn't it?
Yeah, but here it says unfractionated.
But subcutaneous administration of enoxaparin, can we give that?
I guess. Is that low molecular weight?
Yes, enoxaparin is low molecular weight.
Yeah, I guess that will work.
She does not have any other risk factor of not
Ah,
giving this.
mm, she doesn't. Ready?
Yes.
Oh, Jesus. It's out the place.
Oof.
AIV administration of dishes. I swear, I told you, like, emergency medicine. Oh, Lord. Administration, administration at the place is the most appropriate next step in management
We
of
are
this
clearly
patient.
killing plenty of people.
Yeah, it's really bad. I need to review. I don't even know what I need to review. IV administration of active phase is the most appropriate next step in management of this patient with a confirmed PE and evidence of obstructive shock. Yeah. Large PE increase the resistance within the pulmonary artery, sacred and place undue strain on the right ventricle. When this pulmonary resistance exceeds the capability of the right ventricle to maintain forward cardiac output, patients can develop signs and symptoms of shock. Common um, findings include hypoxemia, tachycardia, hypotension, altered mental status. Laboratory markers may demonstrate increased BNP, increased troponin concentration. Bedside echocardiography is useful to measure dilated and hypokinetic right ventricle with bowing of the interventricular receptor into the left ventricle. The decision to give thrombolytics such as ATP should weigh the risk for bleeding with the risk for death from PE. In instances of shock, the risk for death from PE nearly always outweighs the bleeding. Thus, this patient should be given antibiotics as soon as possible. Following thrombolysis, patients should be based on systemic anticoagulation with IV unfractionated heparin. Okay, so it's not hmm, IV unfractionated heparin is one treatment option for patients with low or intermediate risk of PE without evidence of shock. This patient requires thrombolysis. Systemic anticoagulation should be resumed after administration of antibiotics. Similarly, oral warfarin is another option for long-term treatment of PE. But never newer agents such as direct oral anticoagulant or lower molecular weight heparin are typically preferred given their ease in the shock is a primary indication for the use of thrombolytic, which should be given before direct anticoagulant. And it's not, what was the other thing that we were confused? E. Subcutaneous administration of enoxaparin, also known as low molecular weight heparin, is a reasonable treatment strategy to prevent development of DVT and PE, but it's not used for patients with evidence of shock. So the all questions here was because she has shock, which will be the low blood pressure, high pulse, and issue and
So
low.
why we are choosing like altiplase, retiplase?
He's saying that because she's in shock, because she's in obstructive shock.
If he is in normal state, then we can use that things too.
Mm, If she just had the PE, but she's not in shock, then yeah, we will do the heparin thing, the heparin.
Okay. Next.
Oh, it said, look at the educational objectives. It says
Okay.
patient with large PE leading to right ventricular failure and obstructive shock to receive TPA. Systemic anticoagulation with heparin exons, heparin, warfarin, or whatever should be postponed until after the successful administration of TPA and restoration of normal. Yeah. Yeah. Next.
Yes. A 26-year-old woman comes to the emergency department because of her history of shortness of breath, right sided chest pain. She reports shortness of breath when walking from flight of the stairs and flight of the stairs this morning when awakening when walking with friends at a shopping mall earlier. She also has 2-day history of non-productive cough. She has sickle cell disease. Her medications are hydroxyurea and acetaminophen with codeine as needed. The patient was hospitalized for treatment of a painful vaso-occlusive crisis. Hmm, what I'm reading. Okay, her temperature is 38, pulse 104 per minute regular, respiration 20 per minute, blood pressure 128 by 82, pulse oximeter on room air oxygen saturation is 91% improved to 95% with 2-liter oxygen, while nasal cannula fine crackles are heard at the lung beat. The remainder of the examination showed no abnormality: hemoglobin 8.9, hematocrit 25.2, leukocyte count 12,000, platelet count 4 lakh 57,000. An X-ray shows which of the following conditions. Uh, oh,
Hmm. Plastic crisis, a plastic anemia. Plastic anemia, no. Plastic crisis can be that also. Uh,
okay,
mm, mm, one moment. Between a plastic crisis and infection. Plastic crisis is only the hemoglobin that's low, I think, which will fit this. And
this patient has
infection
sickle cell disease, isn't it? Sickle
is
cell disease patient with fever.
plastic.
You need to give antibiotic as fast as possible. Otherwise, his spleen will be cooked.
So it's infection. Infection is the most likely. Oh my God, yeah. Most likely precipitant of this patient acute chest syndrome. Acute chest ACS occurs as a result of vaso-occlusive within the pulmonary microvasculature. Vaso-occlusion within the pulmonary and is diagnosed in patients with sickle cell disease who present with new pulmonary infiltrate in, in the setting of fever or other new respiratory symptoms, including cough, shortness of breath, increased work of breathing, tachypnea, hypoxemia. While ACS is a distinct clinical syndrome, is commonly precipitated by another illness such as bacterial or viral pneumonia, asthma exacerbation, hypoventilation, or fat emboli, among others. It is both impractical and nearly impossible to distinguish ACS from pneumonia. So, nearly all patients receive antibiotics to treat bacterial pneumonia. Additionally, the use of either simple transfusion or exchange transfusion may be component of the therapy. But further treatment involves maintaining anoxia with supplemental oxygen or the use of NPPG, judicious use of fluid, and aggressive pulmonary hygiene measures, including the use of an incentive spirometer. Patients with pulmonary embolism should be placed on a full anticoagulant, um, while all others should receive prophylaxis against venous thromboembolism. Pain should be managed aggressively. Aplastic crisis presents with anemia and a low reticulocyte count, indicating inadequate erythropoiesis, but did not present with fever, pulmonary symptoms, and new infiltrate. In patients with SCD, what is SCD? Oh, sickle cell. Aplastic crisis can be precipitated by infection with parvo B19.
Okay.
Mhm. Next.
A 52-year-old woman with rheumatoid arthritis comes to the emergency department because of 2 hour history of fever, severe malaise, and joint stiffness. She has severe stiffness and pain in the knee, and wrist, hands, and the knee. She also has a history of hypertension. She also has a history of hypertension, hypercholesterolemia. Her medications are prednisolone, etanercept, enalapril, hydrochlorothiazide, ibuprofen as needed. She is sleepy but easily aroused. Her temperature is 101. Pulse 120, respiration 26 per minute, blood grouping 9, blood pressure 90 by 50, pulse oximetry on room air, shows oxygen saturation 92%. The upper and the lower extremities are cool to touch. A grade 2 by 6 ejection systolic murmur is heard at the base S3 and S4. Hemoglobin 9.5, leukocyte count 20,000, platelet count is 90,000, prothrombin times 16, creatinine high, albumin low, sodium normal, potassium. Okay, nice. So
Stiffness. Mm, mm, fever. Jugular venous distension. Hmm.
what is your diagnosis?
I do not know. I don't know
There
what
is
to do.
anemia. There is leukocyte count is probably high.
Yes, I.
Anemia, thrombocytopenia, PT is high. There is no PTT. Albumin low. Creatinine probably normal. Mm,
STEMI she has no chest pain and STEMI.
there is mottling over the lower extremities.
Not and STEMI. GI bleeding.
Crackles are hard.
GI bleeding. GI bleeding. Etanercept or ibuprofen as needed. Probably not GI bleeding. Cardiac tamponade. She doesn't have any, no jugular venous distension, so it's not cardiac tamponade. And between, the only thing that makes sense is sepsis, which does not really make sense, but it wouldn't create that many issues. Uh, uh, yeah, but she has high temperature. Okay, I'll go with that. Probably not that.
Okay, next. Okay, let's see.
Okay, so is sepsis. The patient presentation is not consistent with sepsis complicated by distributive shock. What? Sepsis results from a dysregulated and exaggerated immune response to an infection. Sepsis can be complicated by shock, multi-organ failure with a high mortality rate. Septic shock is characterized vasoplasia, impaired response to vasodilation, I guess. Markedly decreased systemic vascular resistance, increased cardiac output, tachycardia, blah, blah, oliguria, and lactic acidosis, fever, tachycardia, and leukocytosis. Tachypnea and are also part of sepsis. Hypotension, cool, mortal extremities, and end organ dysfunction. Yeah. This patient risk for developing severe infection is increased by the use of oral steroids daily and TNF alpha blockers for rheumatoid arthritis. Okay, next.
Okay. A previously healthy 23-year-old woman comes to the emergency department because of 3-day history of severe left lower abdominal pain and a foul-smelling vaginal discharge. She is sexually active with multiple partners and uses condom inconsistently. Her last menstrual period was 2 weeks ago. Temperature 101.3 degree Fahrenheit. A pulse 110 per minute. Respiration 14 per minute. Blood pressure 110 by 85 millimeter of mercury. Blood pressure 95 millimeter of mercury. Abdominal examination shows tenderness to palpation of the left lower quadrant. Examination cervical motion tenderness show left adduction and left adduction tenderness which of there is foul smelling discharge. Pregnancy test negative. Which of the following is the most appropriate next step to confirm the diagnosis? Ready?
Mm, sure.
Okay.
So it's pelvic ultrasound. Neisseria chlamydia can both cause vaginitis, cervicitis, PID. Risk factors include adolescence. We know that vaginitis typically with mucopurulent discharge and pruritus, cervicitis, similar discharge, but also with red friable cervix. Okay. And cervical motion tenderness on exam. When infection spreads to fallopian tube or ovaries, PID with purulent and foul smelling cervical discharge, uterine adyssal tenderness, and symptoms of fever, systemic symptoms like fever can happen. If left untreated, PID can become complicated by tube ovarian abscess. As in this patient, presenting with focal tenderness and possible focal and mass of physical. Diagnosis can be confirmed by pelvic ultrasound stay complex continuous multilocular treatment, antibiotics, and surgical management. It's not urinalysis and urine culture can be used to evaluate UTI, such as cystitis, pyelonephritis, urinary tract infections commonly present with dysuria, urinary frequency and urgency, blah, 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 fever, constipated understand. This STI, this sexual activation with cervical discharge more likely has PID or urinary. Okay. And it's not blood culture I used to diagnose bacteremia in septic patients. While they may be used in this febrile tachycardia patient with likely infection, they will not confirm the diagnosis of tubal bioanalysis. Okay, next.
Okay. A previously healthy a previously healthy 35-year-old man comes to the emergency department because of progressive redness and swelling of the right knee for the past 3 days. Our temperature is 37 degrees Celsius, pulse 84 per minute, respiration 16 per minute, blood pressure 134 by 74 millimeter mercury. Examination shows 1.5 into 3 centimeter area of swelling and fluctuations over the entire aspect of the right thigh. A photograph is shown. Range of the motion is normal. Which of the following is the most appropriate next step?
Ready?
Yes.
Vision and drainage of the affected area. Abscess occurs in the setting of acute inflammatory response to an infection organism, resulting in an organized collection of pus, the necrotic cellular debris, and infectious organism present. Bacterial abscess presents with cutaneous redness, warm, fluorescence, and purulent drainage, often following inoculation from injury from a spider bite, inoculation from an injury such as spider bite, puncture, or abrasion. Systemic symptoms, including fever, tachycardia, leukocytosis, are often but not necessarily present. Most commonly, abscess formation is acute and results from bacterial infection of the skin. The two most common pathogens to cause bacterial infections of the skin are staph and strep pyogenes. Staph aureus is most likely cause is most likely to cause a bacterial abscess. It causes impetigo, erysipelas, and folliculitis. Other um, less common organism that Clostridium perfidious, which infects an open wound and causes necrotizing fasciitis. Enterococcus fecalis, which causes nosocomial infection, and Pasteurella multiplicida, which causes infection secondary to cat and dog bites. Incision and drainage will be appropriate therapy for an abscess to release the pus and debris to control the source of infection. While the patient may also require oral antibiotics without incision, and drainage your antibiotics will not effectively penetrate the abscess wall. This is most important step. It is not oral antibiotic is inadequate in the case without appropriate surgical drainage. While the patient blah blah blah, the bacterial source control provided by surgical is most critical blah blah. X-ray of the knee is not necessary in this case because there is no suggestion of any involvement of the infection. X-ray of the knee will not provide any information about the soft tissue surrounding the abscess. Imaging is unnecessary in this case. But if X-ray evaluation of tissue was necessary, an MRI would be appropriate.
Next.
Okay.
A 77-year-old woman is brought to the emergency department by her husband after she fell at home. She had a 5-year history of type 2 diabetes mellitus. Medication are metformin and insulin on arrival. She is somnolent. Temperature is 37.7 degrees Celsius. Pulse 130 per minute. Respiration 16 per minute. Blood pressure 78 by 40 millimeter of mercury. Pulse oximeter. The room here shows an oxygen saturation. Basilar bilateral crackles are hard on the lung base. The remainder of the organism normal. Hemoglobin 13.2, sodium 132, potassium 3.1, glucose. Bicarbonate is low. Chest X-ray.
Oh, my thing don't work now. Okay. Scan of the head, toxicology, dextrose, insulin.
Is it DK?
Why?
That's the thing I am thinking. She has 5 year history of.
Even if it was DK, her urine is not. Sorry, her glucose is normal, so it doesn't make sense. I mean, it doesn't make sense. and between the CT scan of the head because she fell, or the administration of saline because her blood pressure is low. But why is the bicarb low too? Bicarb is low. So was she like
Some sort of metabolic acidosis.
metabolic acidosis? Uh, ah,
Okay, pick something.
okay, pick. Okay, let's give saline. Okay, so the answer is yeah, let's give saline. The patient is presenting with shock, and the most appropriate next step is saline. Sepsis is okay. She has sepsis that results from dysregulated blah, blah, blah. Sepsis can be complicated by shock or multi-organ failure with high mortality. Septic shock is characterized by vasodilation with markedly decreased vascular resistance, increased cardiac output, oliguria, lactic acidosis. The presence of I didn't even answer my thing here. Sorry. The presence of hypotension, tachycardia, and thermometer indicates shock, acute stage shock, and the patient requires emergency resuscitation. Isotonic crystalloid solution are effective, inexpensive. Urine, where was the other one? Oh, B. It's not CT scan of the head is not recommended prior to fluid resuscitation because the patient's condition is likely to deteriorate rapidly in the imaging suite if a shock is not first addressed. CT scan of the head may be considered after the patient is stabilized as part of the evaluation of her fault and some knowledge. Okay, so it's the ABC thingy. Okay, next.
Yes. A previously healthy 37-year-old man comes to the emergency department because he has passed black stool during the past 4 hours. He has an episode of severe dizziness and palpitation when he arose from the toilet. He has not had abdominal pain, nausea, no history of ulcer. He does not smoke or drink. He appears pale. Okay, BP 85 by 50 with supine. The abdominal examination shows no tenderness. Uh, Test of the stool for local blood is positive. Examination after intravenous administration of 2 liter, 0.9% sodium chloride, and 3 units of packed red cell. His pulse is 100 per minute, blood pressure 110 by 70. Which of the following is the next step?
Black stools. Do we do colonoscopy or upper endoscopy? It's black. I guess colonoscopy. I'll go with it. Ready?
Yes.
So, it's upper endoscopy. Oh my goodness. Um, what was that? Upper endoscopy most appropriate step patients with signs and symptoms of upper GI bleeding. GI bleeding is often separated into upper and lower GI bleeding. Patients with upper GI bleeding often present with dizziness and lightheadedness, nausea, epigastric pain, melena. Occasionally, as in the case of variceal bleeding, hematemesis may accompany these symptoms. Lab findings may show an increased blood urea, but the decrease in hemoglobin concentration often lags behind clinically significant bleeding. Treatment should initially focus on resuscitation with crystalloids and RBCs as needed. All patients are started on IV PPI and patients with cirrhosis and suspicion variation bleeding should receive octreotide and antibiotics. Major causes of OPGI bleeding, aside from variceal bleeding, include Mallory Weisstier, um, peptic ulcer disease, gastritis, esophagitis, and angiodysphagia. Rare causes include diol Diolafoy lesion, gastric antral vascular ectasia, and orthoenteric fistula. After patients have been stabilized, upper endoscopy should be performed both to determine the cause of bleeding and to intervene on any lesions that are amenable to treatment, such as bleeding ulcers or visible bleeding blood vessels. It's not the colonoscopy is the intervention of choice when patients are suspected of having a source of low GI bleeding, such as diverticulosis and angiodysphagia, which often presents with hematochezia, I guess, red blood cells, red pooping rather than melanoma. CT scan of the abdomen is insensitive for evaluating causes of GI bleeding. Resuscitation followed by endoscopy should be done. If no cause of bleeding is identified, the CT angiography may be able to localize breast bleeding that exists at location distal to the duodenum. Next.
A 2-year-old was brought to the emergency department by his parents 1 hour after he has had generalized tonic-clonic seizure. The seizure lasted approximately 1 minute, and the child was lethargic for approximately 15 minutes 15 minutes afterward. He is not behaving normally. He is not behaving normally for the past 2 days. He has fever, runny nose, loss of appetite. He does not. Uh, he has no history of seizure. On examination, he is awake, interactive, smiling. Rectal temperature is 3900 2.4 degree Fahrenheit. Pulse is 100 per minute. Respiration 24 per minute. Blood pressure 90 by 60. Which of the following is the lab 12, hemoglobin 12 equals at 12,000, segmented neutrophil 56%, band 6%, and lymphocyte 38%. Which of the following intervention most optimal next? Uh,
Hmm. Ready?
yes.
Administration of acetaminophen. Febrile seizures are common presentation in infants and young children. Simple and uncomplicated febrile seizures are generalized and defined as lasting less than 15 minutes, not recurring within 1 day, whereas complex febrile seizures are focal, prolonged, and recurring. It is important to differentiate febrile seizures secondary to viral illness from a bacterial CNS infection, which can also present with fever and seizure. But patients are typically ill appearing and may have signs of meningitis. In patients, okay, so in viral fever and seizures. Uh, yeah, fever and seizures, and in bacterial seizures and systemic infection. Okay. In patient looks here. In patients with febrile seizures that have spontaneously resolved, active treatment with benzo is not necessary, and the fever can be treated symptomatically with antipyretics. Most children who present with simple spiral seizure can be discharged safely as long as they have returned to baseline and parents are given anticipatory guidance and strict return precautions. Children with local or prolonged seizure may require further observation, intervention, and diagnosis, especially if there is delayed recovery of the baseline or prolonged post state. It's not a admission to the hospital for observation may be appropriate for patients with complex febrile seizures, seizures that require treatment with benzo or prolonged recovery baseline. For this patient who presented with a simple febrile seizure and has returned to baseline, discharge is safe. Administration of ceftriaxone or lumbar puncture would be indicated if there was suspicion for meningitis. Meningitis can present with acute headache, fever, photophobia, In the next statement, with variable causes from bacterial, viral or fungus, so children are typically ill affected and may show signs of impairment of status and meningismus. Next.
Okay, next. Sorry. A 54-year-old man is brought to the emergency department because of 2 hour history of chest pain, shortness of breath, nausea that began while he was sitting and working at his desk. He has had one episode of vomiting during this time. And he describes the pain as pressure at radius to the shoulder. He rates the pain as 7 on a 10 scale. The patient says has had three similar episodes of pain during the past 3 months. Previously, they are occurred on exertion and relieved 15 minutes of rest. He has no hypertension, type 2 diabetes, malaria. So vitals is medications are aspirin, metformin, and enalapril. He has smoked one pack of cigarette for 30 years. His temperature is 37 degrees Celsius, past 90 per minute, respiration 20 millimeter of mercury. Including troponin I, ECG, and the chest X-ray. Okay.
Ready?
Okay.
Is myocardial perfusion testing within 3 days. Exertional chest pain accompanied by shortness of breath that improves with rest is stable angina caused by cardiac ischemia from insufficient perfusion during exertion through narrow atherosclerotic um, arteries, coronary arteries. This patient presents with system consistent with unstable angina. Defined by anginas that are new, occur at rest, or worsening in severity. Unstable angina is a type of acute coronary syndrome which requires urgent diagnostic workup, including ECG, troponin test, cardiopulmonary cardiology consultation, and myocardial perfusion testing, stress testing, or cardiac catheterization. Nitroglycerin, a potent vasodilator that decreases cardiac payload and myocardial oxygen demand, making it the first line therapy in the treatment of angina pectoris, along with aspirin, which inhibits platelet aggregation. Patients with unstable angina are stratified on the basis of thrombolysis in yeah, and visit in myocardial infarction score, which assists in identifying the need for therapeutic anticoagulant coronary angiography. In this patient with improving chest pain, normal CG, and serial troponin concentration within range, the most appropriate next step in management is urgent myocardial perfusion testing. It's not the primary care PCP follow-up within 1 week will not be appropriate next step. This patient is presenting with signs, symptoms concerning for unstable angina, which requires urgent cardiac diagnostic testing and cardiology consultation. Next.
Okay. A 70-year so, uh, a 70-year-old woman is brought to the emergency department in the morning by her son because of one day history of intermittent episodes of confusion, agitation. She had an episode of urinary incontinence one night ago. The son says that the patient has otherwise been healthy and previously had normal mental status. Medical history is significant for degenerative diseases. Daily aspirin and acetaminophen. The patient is 5 feet tall, 54 kg, BMI 23. Vital signs are vital signs are temperature 39 degrees Celsius, 102 pulse 110 per minute, blood pressure 110 by 80 millimeter, lungs are clear to solution, abdomen is non-tender. Uh, Mental status discloses orientation to the person but not the place or time. The remainder of the physical examination discloses abnormality, urea nitrogen high, creatinine high, sodium normal, potassium 4.8, bicarbonate low, hematocrit 38, WBC count is very high, 89%.
Ready?
1 minute, please.
Mhm.
Okay, ready.
Okay. So it is urinalysis. Urinalysis study to disclose the diagnosis in this patient presenting with urinary symptoms, evidence of infection, fever, tachycardia, leukocytosis, and renal impairment, increased creatinine concentration. Acute urinary UTI encompasses infections of the urethra, bladder, ureters, kidney, and accessory structures of the GU. Patient's presentation range from asymptomatic or minor urinary tract symptoms like dysuria, increased urinary frequency, incontinence, urgency, nocturia, superfluous discomfort, to more severe systemic symptoms like fever, chills, conservative anger, tenderness, alterment status, especially in older patients. Urinalysis and urine culture are indicated studies to diagnose and identify the bacteria that cause it. Urinalysis typically displays an increased white blood cell count and may demonstrate bacteria, proteinuria, bacteriuria, proteinuria, hematuria, positive leukocyte entering positive nitrates. Serum creatinine concentration may increase secondary to obstructive uropathy from inflammatory of the GU, pyelonephritis, or depletion. Next.
Yes. A 47-year-old man is brought to the emergency department 25 minutes after sustaining a gunshot wound to the abdomen. She is hysterical and is unable to give any other history. Her pulse is 100 per minute, respiration 24 per minute, blood pressure 110 by 75. Examination of the chest shows no abnormality. Abdominal examination shows an entrance wound in the right lower quadrant, no exit wound. The abdomen is mildly tender but not distended. Vital bowel sounds are normal. Bowel sounds are hyperactive. Extra of the chest and the abdomen shows a bullet in the left parasternal. Which of the following is the most likely diagnosis? Oh, we will do.
Ready?
Oh, okay.
Laparotomy. Exploratory anatomy involves the surgical evaluation of the peritoneal cavity and is commonly employed in the diagnosis of and management of abdominal trauma, bowel obstruction, peritonitis, and differentiated cases of acute abdomen. In penetrating abdominal trauma, evaluation of the depth of the wound track is quickly done to determine whether it has violated the peritoneum. Gunshot wounds are particularly high energy and can cause severe intraperitoneal injury, including hemorrhage and viscous perforation. Aparotomy of the abdomen is indicated for hemodynamically unstable patients presenting after penetrating abdominal trauma because it permits the control of hemorrhage and the repair of identified injuries. Um, in stable cases, imaging precedes surgical intervention. Yeah.
Next.
Mhm.
Okay. 49.
Yeah.
27-year-old man is brought to the emergency department 2 hours after he was involved in a head-on motor vehicle collision. He was unrestrained front passenger. Examination of the right lower extremity showed dislocation and a dislocated knee. Dislocation and dislocated knee sensation is absent from the knee to the toes. There are no palpable pulses distal to the femoral artery. No motor activity is present. Which of the following is the most which of the following is the most appropriate next step in the management?
Ready?
1 second. Okay.
With reduction of the dislocated knee. Um, Posterior knee dislocations may occur secondary to posteriorly directed force against the proximal fibula, yeah. Such as in the setting of motor vehicle accident. Posterior knee dislocation places traction on the popliteal artery and branches of the sciatic nerve. Such an injury can result in potential neurovascular insufficiency in the leg distal to the level of injury, resulting in permanent loss of function if untreated. Arterial injuries sustained during posterior knee can include dissection, rupture, thrombosis, tramural hematoma, pseudoaneurysm. Imaging including arteriography, NCT angiography is useful to investigate the presence of underlying arterial injuries or to facilitate operative repair planning. Prompt reduction of the knee dislocation serves to limit the extent of injury by relieving the neurovascular traction, thereby minimizing damage to and restoring nerve function and arterial flow. Pursuit of imaging should not delay the reduction of the dislocated knee. It's not nerve conduction studies are useful for diagnosis of nerve injury or demyelinating disease, such as MS, blah, blah, blah. It's not F arteriography. May be useful for identifying popliteal injury, artery injury. However, pursuing additional image find to reduction of the dislocated knee will lead to delays in treatment and will prolong the period of neurovascular compression. Yeah.
Okay.
Mhm.
A 23-year-old man is brought to the emergency department 45 minutes after he was bitten by a rattlesnake on the left hand. He has no history of serious illness, takes no medication. He has no allergen, temperature 37, pulse 100, respiration 23, blood pressure 134 by 76, pulse oximetry on the room here, oxygen saturation 98%. Physical examination shows swelling, dislocated, and severe tenderness on the left hand. The physician administer quartile polyvalent 5 antivenom 15 minutes. The patient becomes obstinate and flushed. Temperature is 38. Respiration 35, blood pressure. Which of the following?
30?
Yes, is it anaphylaxis?
Oh shit, I thought it was acute serum. It's anaphylaxis. Anaphylactic shock, a severe type 1 hypersensitivity reaction presents following exposure to an allergen. It is caused by widespread IgE-mediated mast cell degranulation, and is characterized by histaminergic responses within minutes, within multiple organs, leading to flushing, angioedema, bronchospasm, nausea, vomiting, abdominal disruption, vasodilation, which can lead to airway obstruction and circulatory collapse. It's generally acute and in onset following a specific exposure generally does not self-resolve. If not managed properly, death can occur due to hypoxia and distributive shock. Anaphylaxis is a form of distributive shock, which is characterized by primary reduction in systemic vascular resistance. This reduction in SVR is secondary to IgA-mediated system, whatever. Cardiac output increases to compensate for the low SVR in the early stages of distribution. If the inciting state is not appropriately treated, further decompensation can occur, resulting in progressive hypotension and insufficient perfusion with associated end organ damage. After administration of epinephrine, full resuscitation should be initiated to increase intravascular volume to support adequate organ perfusion. It's not acute sickness, serum sickness. It's a type 3 immune complex mediated hypersensitivity reaction in which antibodies to foreign proteins are produced and immune complex deposit in membrane, leading to tissue damage. It typically presents with fever, urticaria, arthralgia, fever, urticaria, arthralgia, proteinuria, lymphadenopathy, 5 to 10 days after exposure. Anaphylaxis is typically immediate and acute. Okay, we are done.
Yes.
Okay, I'll see you tomorrow.
Okay. Bye bye.